Welcome back to Medcran Medical. Today we shall be looking at the valvular heart diseases. To start with, valvular heart diseases are any cardiovascular disease processes that involve either one or more of the four valves of the heart. Normally, your heart has four valves. The aortic and mitral valves that are located on the left side of the heart, and the pulmonic and tricuspid valves which are located on the right side of the heart. These valvular heart conditions occur largely as a consequence of aging, but may also be a result of congenital anomalies or specific diseases or physiologic processes that include either rheumatic heart diseases and pregnancy. Anatomically, the valves are part of the dense connective tissue of the heart, which is known as the cardiac skeleton. These valves are responsible for the regulation of blood flow through the heart and the blood vessels. A valve failure or a valve dysfunction can result in a diminished heart functionality, though the particular consequences of these conditions are dependent on the type and the severity of a vascular disease. The treatment of these damaged valves may involve either medication alone, but often involve surgical valve repair known as valvoplasty or valve replacement. Valvular heart diseases can either be classified as valvular stenosis or valvular insufficiency. A stenosis and insufficiency or regurgitation represent these dominant functional and anatomic consequences that are associated with valvular heart diseases. Irrespective of the disease process, alterations to these valves occur that produce one or a combination of these conditions. And insufficiency and regurgitation are usually synonymous terms which describe an inability of the valve to prevent the backflow of the blood as the valve leaflets of the fail to join correctly. On the other hand, stenosis is the narrowing of the valvular orifice that prevents adequate outflow of blood. It can result in insufficiency if thickening of the annulus or the leaflets results in an inappropriate leaf closure. Let us start by discussing the aortic and mitral valve disorders. Aortic and mitral valve diseases are usually termed as left heart diseases. These diseases are more prevalent than the disease of the pulmonary or tricuspid valves due to the higher pressures that are on the left heart. The stenosis of the aortic valve is usually characterized by either thickening of the valvular annulus or the leaflets, limiting the ability of the blood to be ejected from the left ventricle into the aorta. Stenosis is typically the result of a vascular calcification, but may also result from congenitally malformed bicuspid aortic valves. So this defect is characterized by a presence of only two valves leaflets. Therefore, this defect is characterized by the presence of only two valve leaflets. It may occur in isolation or in connect with other cardiac anomalies. An aortic insufficiency or regurgitation is characterized by the inability of the valve leaflets to appropriately close at the end of each systole. This allows blood to flow inappropriately backwards into the left ventricle. So the causes of an aortic insufficiency in the majority of the cases are unknown or idiopathic, but they may result from either connective tissue disorders or immune disorders, for example, Marfan syndrome or a systemic lupus erythematosus. The processes which lead to aortic insufficiency usually involve a dilation of the valve annulus, therefore displacing the valve leaflets which are anchored into the annulus. The second type of valvular heart diseases that we are looking at is the mitral stenosis and the insufficiency. A mitral stenosis is caused largely by the rheumatic heart diseases, though sometimes it can result from calcification. In some cases, the vegetations form on the mitral leaflets as a result of endocarditis, which is an inflammation of the heart tissue. The mitral stenosis is an uncommon condition and is not as age-dependent as other types of valvular heart diseases. On the other hand, a mitral insufficiency is caused by a dilation of the left heart, often as a consequence of the heart failure. In these cases, the left ventricle of the heart becomes enlarged, causing the displacement of the attached papillary muscles which control the mitral valve. The third type of valvular heart disorders are the pulmonary and tricuspid valve disorders. The pulmonary and tricuspid valve diseases are known as right heart diseases. So, a pulmonary valve disease is the least common heart valve disease in adults. And pulmonary valve stenosis is as a result of a congenital malformation and is observed in isolation or as part of the larger pathologic processes, for example in tetralogy of Fallot, Noonan syndrome, and a congenital rubella syndrome. Unless the degree of stenosis is severe, individuals with pulmonary stenosis usually have excellent outcomes and treatment options. On the other hand, a pulmonary valve insufficiency occurs commonly in more healthy individuals to a very mild extent and does not require intervention. So a more appreciable insufficiency is typically the result of damage of the valves that occurs due to cardiac catheterization, intra-aortic balloon pump insertion, or other surgical manipulations of the heart valves. Additionally, an insufficiency may be the result of carcinoid syndrome, inflammatory processes, for example rheumatoid disease, or endocarditis, or a congenital malformation. Pulmonary valve insufficiency may also be secondary to severe pulmonary hypertension. Then lastly, we have a tricuspid valve disorders. A tricuspid valve stenosis without a concurrent regurgitation is a highly uncommon and typically the result of these rheumatic diseases. It may also be a result of a congenital anomalies, a carcinoid syndrome, obstructive right artery tumors, typically lipomas or myxomas, or sometimes hypereosinophilic syndromes. A minor tricuspid insufficiency is a commonly occurring condition in healthy individuals, and in most severe cases, it is a consequence of dilation of the right ventricles, leading to the displacement of papillary muscles which control the valve's ability to close. A dilation of the right ventricle usually occurs secondary to a ventricular septal defect, that is the right to left shunting of blood, a Menger syndrome, hyperthyroidism, and pulmonary stenosis. A tricuspid insufficiency is known also to result from congenital defects of the tricuspid valve, for example Ebstein's anomaly. What are the causes and risk factors for these valvular heart diseases? The first identifiable cause is the calcific disease. Calcification of the leaflets of the aortic valves is a common condition which occurs with increasing age, but the mechanism is more related to increased lipoprotein deposits and inflammation than the normal wear and tear of advanced age. An aortic stenosis usually occurs due to calcification with age, comprises of more than 50% of the diseases. Aortic stenosis due to calcification of a bicuspid aortic valve comprises about 30 to 40% of the total aortic stenotic diseases. When you look at the aortic stenosis that occurs due to calcification of tricuspid valve, its prevalence is more than 50% of the diseases. So aortic stenosis due to calcification of a bicuspid valve comprises about 30 to 40% of the diseases. So hypertension, diabetes mellitus, hyperlipoproteinemia, and uremia may speed up this process of valvular calcification. The second cause is dysplasia. Heart valve dysplasia is an error in the development of any heart valves and the common cause of these congenital defects in humans as well as in animals. A tetralogy of Fallot is a congenital heart defect with 4 abnormalities, one of which is a stenosis of the pulmonary valve. In Ebstein's anomaly, where the tricuspid valve is present, can lead to a tricuspid valve regurgitation. So a bicuspid aortic valve is an aortic valve with only 2 cusps as opposed to the normal 3 cusps. It is present in about 0.5 to 2% of the general population and causes an increased calcification due to a higher turbulent blood flow through this valve. Then the third cause is a connective tissue disorders, for example Marfan syndrome, which is a connective tissue disorder leading to chronic aortic and mitral valve regurgitation. An osteogenesis imperfecta is a disorder in the formation of a type 1 collagen that also leads to chronic aortic regurgitation besides Marfan syndrome. The fourth cause is an inflammatory disorder. This inflammation of the heart valves that occurs because of endocarditis is usually due to a bacterial infection and may also be due to cancers, for example bronchitic endocarditis. Some certain autoimmune disorders like Lehmann-Sachs endocarditis are seen in systemic lupus erythematosus and hypereosinophilic syndrome, which is known as lupus endocarditis. An endocarditis of the valves can lead to regurgitation through that valve, which is seen in the tricuspid, mitral, and aortic valves. Some certain medications have been associated with valvular heart diseases. Most prominently, we have a drug known as ergotamine derivative, for example, pegolide and cabergoline. Some diseases of the aortic root can cause chronic aortic regurgitation, and these include a syphilitic aortitis, Behçet's disease, and reactive arthritis. Another cause of these valvular heart diseases is the heart disease itself. A tricuspid regurgitation is usually secondary to heart right ventricular dilation, which may be due to left ventricular failure. The most common cause is the right ventricular infarction, an inferior myocardial infarction, or a col pulmonale. Other causes of tricuspid regurgitation are a carcinoid syndrome and a myxomatous degeneration. We have these individuals who fall into special populations when it comes to valvular heart disease, for example, pregnancy. The evolution of individuals who have valvular heart diseases who are or wish to become pregnant is a difficult issue normally in medical practice, and issues have to be addressed, including the risks during pregnancy to the mother and the developing fetus in the presence of a maternal valvular heart disease as a pre-existing disease in pregnancy. Normal physiologic changes during pregnancy requires an average of about 50% increase in the circulating blood volume that is accompanied by an increase in the cardiac output and usually peaks between the midpoint of the second and third trimesters of pregnancy. The increased cardiac output is due to an increase in the stroke volume and a small increase in the heart rate, averaging to about 10 to 20 beats per minute. Additionally, the uterine circulation and the endogenous hormones cause a systemic vascular resistance to decrease and disproportionately lowering the diastolic blood pressure, causing a wide pulse pressure. An inferior vena cava obstruction from a gravid uterus in the supine position can result in an abrupt decrease in cardiac preload, which leads to hypotension with a weakness and lightheadedness. So during labor and delivery, cardiac output increases in part due to associated anxiety and labor pains, as well as due to the uterine contraction, which will cause an increase in systolic and diastolic blood pressure. So some valvular heart lesions that are associated with high maternal and fetal risk during pregnancies include a severe aortic stenosis with or without symptoms, an aortic regurgitation with NYHA functional class 3 and 5 symptoms, a mitral stenosis with a functional class 2 and 4 symptoms, mitral regurgitation with the functional class 3 and 4 symptoms, an aortic or a mitral valve disease resulting in a severe pulmonary hypertension, an aortic and a mitral valve disease with a severe left ventricular dysfunction, that is an ejection fraction that is less than 0.4, a mechanical prosthetic valve requiring an anticoagulation therapy, a Marfan syndrome with or without aortic regurgitation. In those individuals who require artificial heart valves, consideration must be made for deterioration of the valve over time for versus the risk of blood clotting in pregnancy with some mechanical valves in the resultant need of drugs in pregnancy. In individuals who require artificial heart valves, consideration must be made in those individuals who require artificial heart valve a consideration must be made for any deterioration of the valves over time versus the risk of blood clotting in pregnancy with mechanical valves with the resultant need of drugs in pregnancy in the form of anticoagulation therapy. So, having looked at these conditions, what are the signs and symptoms of a person having these valvular heart disorders? In an aortic stenosis, the symptoms may include a heart failure symptom, for example, dyspnea or exertion. In aortic stenosis, the associated symptoms may include heart failure symptoms, for example, dyspnea or exertion, orthopnea, a paroxysmal nocturnal dyspnea, angina pectoris, and a syncope that is usually an exertional syncope. Some medical signs of aortic stenosis are a pulsus parvus etardus, that is diminished and delayed carotid pulse. A fourth heart sound may be heard, decreased A2 sound, a sustained apex beat, and a precordial 3. When performing an auscultation, you may hear a systolic murmur of a harsh crescendo decrescendo type that is heard on the second right intercostal space and radiating to the carotid arteries. Signs and symptoms of aortic regurgitation include dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, palpitations, and angina pectoris, which are the normal heart failure symptoms. And in acute cases, these patients may experience cyanosis and a circulatory shock. Some medical signs which are associated with aortic regurgitation are, for example, an increased pulse pressure by an increased systolic and a decreased diastolic blood pressure. But these findings may not really be significant if this aortic regurgitation is in acute phase. The patient may have a diastolic decreased sendo murmur. These patients with aortic regurgitation may present with a diastolic decreased sendo murmur that is best heard on the left sternal border, a water hammer pulse, Austin Flint hammer murmur, and a displaced apex beat down to the left. These patients with aortic regurgitation may present with a diastolic decrescendo murmur that's best heard on the left sternal border, a water hammer pulse, Austin Flint murmurs, and a displaced apex beat down to the left. A third heart sound may be heard in these patients with aortic regurgitation. In cases of mitral regurgitation, these patients may present with some normal heart failure symptoms, for example, dyspnea on exertion, orthopneas, paroxysmal nocturnal dyspneas, pulmonary edemas, and palpitations. And on auscultation, these patients may have an holosystolic murmurs at the apex that is radiating to the back or the clavicular area. A third heart sound and a loud palpable P2 may be heard best when these patients are lying on the left side. Patients also commonly have atrial fibrillation, and they may have a lateral displaced apex beat that is oftenly with a heave. In acute cases, these heart murmurs and tachycardias may be the only distinctive signs of mitral regurgitation. Moving to tricuspid regurgitations, these are the patients who will also present with features of right-sided heart failure. For example, ascites, hepatomegaly, edemas, and jugular venous distension. Some signs of tricuspid regurgitation may include a pulsatile liver, a prominent V-waves and rapid wide decreases in jugular venous pressure. Some signs of tricuspid regurgitation may include a pulsatile liver, a prominent V-waves and a rapid wide descents in a jugular venous pressure. Anoscaltatal findings may include an inspiratory third heart sound at the left lower sternal border and a blowing holocystic murmur at the left lower sternal border, and intensifying with inspiration and decreasing with expiration in Valsalva maneuvers. So these patients may have a parasternal heave along the left lower sternal borders. Atrial fibrillation is usually present in patients with tricuspid regurgitation. How do you diagnose valvular heart diseases? Let's start with, again, aortic stenosis. Patients who are suspected to have aortic stenosis may have a chest X-ray findings that shows a dilation of the ascending aorta, but may also have a completely normal chest X-ray. So a direct visualization of calcifications and chest rays is an uncommon condition, an uncommon finding. Other findings which include the dilation of the left ventricle. An electrocardiogram typically shows a left ventricular hypertrophy in these patients with severe stenosis, but sometimes it may also show signs of left heart strain. When performing an echocardiography, it shows a left ventricular hypertrophy, leaflet calcification, and an abnormal leaf closure. An echocardiography, on the other hand, is usually the best diagnostic or a gold standard diagnostic test that shows a left ventricular hypertrophy, left leaflet calcification, and an abnormal leaflet closure. In aortic regurgitation, a chest X-ray is not as sensitive as the other tests, but it may show an aortic root dilation, especially in cases involving aortic roots and the apex displacement. When doing an electrocardiogram, it may show a left ventricular hypertrophy and some signs of left heart strain, a left axis deviation, which may be a sign of an advanced disease, and an echocardiogram may be very helpful in determining the root cause of the disease, as it will clearly show the aortic root dilation or a dissection if it exists. Typically, this pump function of the heart during systole is normal, but echocardiogram will show some flow reversal during diastole. And this disease is usually classified using a regurgitant fraction, or an amount of volume that flows back through the valves divided by the total forward flow through the valves during systole. Regurgitant fraction is measured. In severe cases, this regurgitant fraction is greater than 50%, while progressive aortic regurgitation has a regurgitant. In severe cases, there is a regurgitant fraction of more than 50%, while progressive aortic regurgitation may present with a regurgitant fraction of 30 to 49%. In mitral stenosis, and a chest X-ray will show an enlarged left atrium and may show dilation of the pulmonary veins. An electrocardiogram shows a left atrial enlargement that is due to an increased pressure on the left atrium. And an echocardiogram is helpful in determining the severity of the disease by the estimation of the pulmonary artery systolic pressures, and this can be done to show a leaflet calcification and a pressure gradient over the mitral valve. So a severe mitral stenosis is usually defined as a mitral valve area of less than 1.5 centimeters squared. A progressive mitral stenosis has a normal valve area but will have an increased flow velocity across the mitral valve. Then in a mitral valve regurgitation or a mitral regurgitation, a chest X-ray may show an enlarged left atrium as well as a pulmonary venous congestion, and can also show some valvular calcification, specifically with combined mitral regurgitation and stenosis due to rheumatic heart diseases. An electrocardiogram shows a left atrial enlargement but can sometimes show right atrial enlargement if this disease is severe enough to cause a pulmonary hypertension. Echocardiogram, on the other side, is useful in visualizing the regurgitant flow and calculating the regurgitant fraction, which can also be used to determine the degree of calcification and the function and closure of the valve leaflet. A severe mitral regurgitation disease has a regurgitant fraction of greater than 50%, while a progressive mitral regurgitation has a regurgitant fraction of less than 50%. In aortic stenosis, its treatment is not necessary in asymptomatic patients. Unless the stenosis is classified as a severe based on the hemodynamics, then it warrants a treatment. Both asymptomatic, severe, and symptomatic aortic stenosis are treated with aortic valve replacement surgery. So a transcatheter aortic valve replacement is an alternative to aortic valve replacement surgery, surgical, and is recommended in high-risk patients who may not be suitable for some surgical aortic valve replacement surgeries. Any angina pectoris that is treated with short-acting nitrovasodilators, beta blockers, or some calcium channel blockers. Any hypertension is treated aggressively, but the caution must be taken in administration of beta blockers in this management of hypertension, and any heart failure is treated with digoxin, diuretics, nitrovasodilators, and if not contraindicated, cautious in-patient administration of angiotensin II converting enzyme inhibitors. A moderate stenosis is monitored with echocardiogram every 1 to 2 years, possibly with supplementary cardiac stress test, and in severe stenosis, we monitor these echocardiogram studies every 3 to 6 months. In aortic regurgitation is treated with aortic valve replacement, which is recommended in patients with symptomatic severe aortic regurgitation. An aortic valve replacement is also recommended in these patients who are asymptomatic but have a chronic severe aortic regurgitation and a left ventricular ejection fraction that is less than 50%. Hypertension is treated with patients with chronic aortic regurgitation, with antihypertensives of choice being calcium channel blockers, angiotensin converting enzyme inhibitors, or angiotensin receptor blockers. Also, endocarditis prophylaxis is indicated before any dental, gastrointestinal, or genitourinary procedures. And in mild to moderate aortic regurgitation cases, you should follow with echocardiogram and stress test every 1 to 2 years. In severe, moderate, severe cases, patients should be followed with echocardiogram and cardiac stress test or an isotope perfusion imaging every 3 to 6 months. Then in a mitral stenosis, patients who have symptomatic severe mitral stenosis get managed using a percutaneous balloon mitral valvoplasty. If this procedure fails, then it's necessary to undergo a mitral valve surgery, which involves a valve replacement, valve repair, or a commissurotomy. Anticoagulation is recommended for these patients who have mitral stenosis in the setting of any atrial fibrillation or a previous embolic event. There's no therapy that is required for symptomatic patients who have mitral stenosis, and diuretics may be used to treat pulmonary congestions or pulmonary edema. And in mitral regurgitation, Surgery is recommended for chronic severe mitral regurgitation in symptomatic patients with the left ventricular ejection fraction of greater than 30% and asymptomatic patients with left ventricular ejection fraction of 30 to 60% or left ventricular end diastolic volume of greater than 40%. A surgical repair of these leaflets is preferred to mitral valve replacement as long as the repair is feasible. So some mitral regurgitation may be treated medically with vasodilators, diuretics, digoxin, antiarrhythmics, and chronic anticoagulation. A mild to moderate valve regurgitation should be followed with echocardiography and stress tests every 1 to 3 years. And in severe mitral regurgitation, we do echocardiography every 3 to 6 months. Thank you for watching this video to the end. Let's meet in our next tutorial.